All right, let's get started. Next slide. So welcome everyone. Dr. Mila Brujic, I can't even tell how many times that I've worked with you. And it is always a pleasure and a huge fan favorite. So can't wait to get started. So I'd like to introduce our speaker. Dr. Mile Brujic is a 2002 graduate of the New England College of Optometry. He is a partner of Premier Vision Group, a successful four-location optometric practice in Northwest Ohio. He practices full-scope optometry with an emphasis on ocular disease, management of the anterior segment, and specialty contact lenses. He is active at all levels of organized optometry. Dr. Brujic is one of the editorial board for a number of optometric publications. He has published over 450 articles. That's it? Just 450? And has over 2,100 lectures, both nationally and internationally, on contemporary topics in eye care. Looking forward to it. Let's do it.
Well, thank you for being here this evening. And thank you, Woo You, for having me here. Stephanie is a near and dear friend, and just seeing what she's created on this platform is absolutely awesome. And before we continue with the discussion, first and foremost, happy birthday, America. For those of you that are on, thank you for being here, especially the East Coasters, where we're getting close to that fireworks time here pretty soon. I do want to make sure that I'm just sending out a quick note here just to let you all know that I will be answering questions throughout the discussion. So if I say something that isn't crystal clear, if I say something that you have questions about or that you want more clarifications on, I'll have my Q&A box open. Just make sure that you type the question in the Q&A box so that I can see it and I'll answer it on the spot. Now, I have had the good fortune of working with a number of companies within eye care, and these companies are listed on this slide. And I truly hold the relationships that I have with these companies near and dear to my heart. I work with them in a variety of capacities through their speaking, writing, acting in advisory capacity, or performing research for these companies. And really the role that I have the most fun with is that direct consultative role where these companies are asking us, the clinicians on the ground floor, where did the technologies that we delivered to you hit right on the mark where we said they were or said they were going to? And where did the technologies miss the mark? What did we communicate to you that was unexpected when you actually had the technologies in your hand? And in addition to that, what are other utilizations for the technology? So again, being able to marry clinical practice or the clinician's perspective with the companies that are creating those technologies, in my mind, has always been the best recipe for giving patients the best outcomes, because that's where, in my mind, true innovation lies, when the clinician and the companies that create those technologies actually formulate these relationships together to really push things forward for better patient outcomes. All financial relationships have been mitigated in this discussion. And really what we're going to be talking about this evening is simplifying dry eye in a world of complexity. And there are several things that you need to understand about my background. First and foremost, I did share with you the companies that I work with, but on a day-to-day basis, I'm a clinician. I'm a part owner of a four-location practice in Northwest Ohio, Premier Vision Group, and I see patients on a daily basis. So in light of everything else that I do, in light of even the education that I'm providing this evening, really where my passion lies is caring for patients in the trenches. So the information that I'm sharing with you is oftentimes going to be very directly related to patient treatments that I'm performing and patient outcomes that I'm performing. But this space has become a little bit intriguing because it has become complicated very, very quickly. For those of you that don't understand why I have a passion in ocular surface disease and dry eye and specialty lenses for that matter, you need to understand and hear this story. And it was back in 2005. So again, I know what most of you are thinking. There's no possible way this guy could have been in practice since 2005. He looks too young to be that practicing for that long. It is in fact true. I actually graduated in 2002, but became a partner of the practice that I'm currently in 2005. A patient who I prescribed glasses to came back to my office a month after I prescribed those glasses saying, I can't see anything out of these glasses. And when she read the visual acuity chart for me, she had that standard fluctuating vision response that we see in dry eye patients. I took her glasses off. I put fluorescein on the eye. I kind of remembered that, hey, this is a good diagnostic tool for dry eye. It sounds like she might have some fluctuating vision. And what I saw was a reduced tear film breakup time at about 1 to 2 seconds. And I saw massive bands of corneal staining inferiorly. And I had to pull the slit lamp back and explain to her why her vision wasn't as good as she was expecting it to be out of these new glasses. Here's the two things that happened to me during that experience. One, I felt fortunate that she came back to me so that I could actually right what I did initially wrong. And the second thing was the question she asked me after I described everything to her. So she sat in the chair and she looked at me and she said, "Oh," said, "did my new glasses give me dry eye?" And as crazy clinically as that sounds to us, that one statement changed the rest of my career. That one perspective kind of pushed me back a little bit, and I had to reinvent the way that I cared for patients. Because at that time, I realized I needed to do something better to screen for this condition that we didn't know very much about at the time. And I needed to screen for it so that I could at least educate people about it and allow the opticians that were in my optical to make sure that they knew that somebody had an underlying dry eye disease. And we would at times have these patients come back a week, or excuse me, a month, 2 months, 3 months later to be re-refracted in order to make sure we're getting them the best vision. But ultimately, I never wanted anybody walking out of my optical thinking they didn't see as best as they possibly could because I missed something in the exam room. So here's the kind of fortunate part of my story. I for lack of a better way to describe it, I saw the light. And I saw the light as an opportunity to help people see better and also to make sure that I was safeguarding what at the time was the most profitable part of the practice, that optical portion. Well, little did I know the innovation within the dry space that was coming down the pipe. Because as I started doing this more, as I started screening for these individuals more, I realized what was truly out there. I realized what I was overlooking. I realized what I was simply looking over. And I also realized that I've probably lost patients because they probably paid good money for glasses in my optical and they didn't see as well as they wanted to. So now we're in 2024. So we're 19 years later. And I'm going to kind of go back and forth in time here because that's what gives you the perspective on where I'm sharing this from. So when you go back to 2005, when I really kind of started this journey, and again, between 2002 and 2005, I wasn't really part of the dry journey. 2005 was that pivotal moment where I shifted things. I'm going to share with you how I shifted things in just a moment here. But it was really a linear path. You diagnose somebody with the tools that we had. And at the time, it was either symptoms, patients experiencing dry eye issues, and or what we were seeing at the slit lamp. And the treatment was essentially relatively basic. We had one approved medication for dry eye. We had corticosteroids that we're using in an off-label manner, and we had artificial tears. That's it. Any heat, any warming devices on the surface of the eye that were utilized on the lids were things like rice in socks that were placed in microwaves. I think about that and I always kind of joke around. I hope that when I shared that information with people, they were actually using clean socks as opposed to dirty socks. And then we started to see innovation in the space. And as we started to see innovation in the space, companies told us, hey, you can diagnose this from different ways and different perspectives. There are different forms of dry that you need to be cognizant of. And we're going to take you to that treatment, but a little bit different way because we perceive this or we see this as being caused by something different. And as we kept going in time, we started to see that the dry eye algorithms started to become increasingly complex. If you have a primary eye care practice today where you're not actively managing dry eye or you're what I call, trying to help people alleviate some of the symptoms with artificial tears and things like that, but you don't feel like you have that really good process in your practice. You sometimes feel overwhelmed when you go into CEs. I certainly did. I was walking into these CEs and I was hearing these things that were happening. And at the end of it, although it seemed logical as we were going through the continuing education process, I get back to my practice and I sometimes would feel more lost than I actually felt directed in terms of how I was going to care for these patients. So I realized there needed to be a better way to decomplex this whole thing, to simplify this whole thing, to make it so that we could follow a logical path and demystify some of this complexity. Here's step one. Step one is to take stock of the technologies that you currently have in your practice. What does that mean? That means understanding all the diagnostics and all the therapeutics that you currently have in your office. So what do you have in your office? Well, a lot of times we just don't even write the slit lamp down because, well, we assume we have a slit lamp. The slit lamp and our brains are the two most important things that we can do to identify dry eye disease. All the other stuff is going to be supplementary. And I think that most of the time we get caught up in the new diagnostics and we feel that if we incorporate diagnostic XYZ, we're going to create a dry eye practice. If we incorporate treatment XYZ, we're going to develop a dry eye practice. And the challenge with that philosophy is if you don't have a process in place where you can add it to, it becomes a very, very difficult thing to add into the process. If you spend 50,000, 100,000, $150,000 on a diagnostic or a treatment option, but you don't have a process in place where you see the unmet need for that technology, what that technology ends up being is a large expense in the office that becomes sometimes the largest paperweight that you have in your practice. When these technologies are used correctly, they fulfill patient unmet need. So step one, let's figure out what we have in our own practices. And everybody's office is going to be different. I like to consider my practice from an ocular surface perspective to be highly advanced. We're always seeking out the newest technologies. But here's something that every single one of us has. Every single one of us has fluorescein strips. Every single one of us has a cobalt blue setting on our slit lamps. Most of us have a Ratten filter. If you don't, they're easy to get. You just go to your nearest camera store. You can actually get these nice fancy ones that are actually kind of a plastic yellow Ratten number 12 filter, or you can call your specialty lens labs that oftentimes give them out directly to you. The only thing is the one from the specialty lens labs, those things tend to wear out just a little bit, but you just order more when you need them. And most of us have lissamine green in our practice as well, too. Here is where we start getting into some more advanced diagnostics. Well, I have a picture of a transilluminator here over on the left-hand side. We all have that. We're going to talk about why that's important here in just a moment. What we don't all have is we don't all have the Scout Pro from Trucara, which measures tear osmolarity, or the meibomian gland evaluator, which in my mind, I think every practice should have, or the inflammadry test that measures inflammation levels on the surface of the eye, or a LipiView that actually gives us the ability to measure meibomian gland structure, or speed questionnaires. Most of us can very, very easily download a speed questionnaire off of the website or off of a website, or the Versea new tier point of care testing platform that assesses for lactoferrin levels and Ig levels. Some of these technologies we have, some of these don't, but we need to take stock in what we actually do have. And from a therapeutic perspective, we also need to take stock in what we have. So we have here some advanced procedures. We have the iLux, we have the LipiFlow system, we have the TearCare system here towards the bottom. We have the BluffX here on the upper left. We have amniotic membranes here. This is the cryopreserved with the actual plastic ring. There are also non-cryopreserved membranes that are available. We have an IPL here. We also have low light level therapy. We have punctal occlusion. Now there's actually a punctal occluder called Lacrofil where you can actually inject sodium hyaluronate within the punctum, and it actually acts as a filler in that region to prevent tears from actually draining into that punctum and that canalicular tract. So we've talked about all of this. And I just told you we were going to simplify this. And what I immediately did was I complicated it for you. So now let's take a step back. Let's simplify this whole process from a diagnostic perspective. And let's talk about the things that every single one of us in our office have. And that is the slit lamp. And every single thing that we do diagnostically when we're assessing for dry eye, we need to be thinking in our minds, is this a cause of the dry eye or the symptoms that the patient's experiencing? Or is this a result of what the patient's experiencing. And this becomes increasingly important, especially when we start talking about some of the signs that we see on the ocular surface, specifically the cornea and conjunctiva. So what you're looking at here, and something that if you've ever seen me lecture on any anterior segment disease, you'll always see me show this. And just to bear with me here, this is a video of me at my slit lamp. Every single thing that you see, every video, every image, are images of me that I've taken from my slit lamp. When you look at this patient on the left-hand side versus the individual on the right-hand side, you can actually see that it's the same individual. The only difference is that I'm literally looking at this patient at a low mag on the left-hand side and on high mag on the right-hand side. Now, what do you see from this? Well, on the left-hand side, you see somebody who maybe has a mild blepharitis, and that's kind of all you notice. When you do nothing more than increase the magnification, I want to point out several things. First and foremost, take a look at the waxy deposits or the collarettes that are present at the base of the lashes. You immediately understand and respect what that can actually do to an individual's symptoms. In addition to that, take a look at the vascular supply here. It's much closer to the surface of the skin than we would expect it to be in this individual. And that's actually a process of vascularization and hyperemia that occurs in these patients or individuals with blepharitis. I want to give you another example here just to share with you how important this little technique is. And I will go as far as to say that 22 years ago, when I graduated optometry school, I will make the case that I was probably taught incorrectly how to assess the lid margin, because the way that I was taught, wide beam, low magnification, take a look at it. And if you do that, you'll miss what I believe to be the underlying cause of a lot of these dry eye issues. So when you have the patient look down, this is low mag. Many of you would say, yeah, I think this patient has a mild blepharitis. Now, all I'm going to do with this patient is take it from 6x to 10x, and that's what it looks like. Now I'm going to take it 10x to 16x, and that's what it looks like. And now I'm going to take it 16x to 25x, and that's what this patient looks like. If I showed you this clinical picture right here, most of you would say, oh, maybe it has a mild blepharitis. I don't think there's anybody on the call that would say, oh, this patient has an insignificant blepharitis here. And at this point, you can see the waxy buildup on almost every single lash that's present on this patient's eye. In addition to that, take a look at this right here. So you see this, what I call tenting at the base of the eyelash. That's actually an eyelash that has a collarette that's just about ready to extrude from that small little lash follicle. So it hasn't yet, but this is the process that occurs right before we physically see the collarette on clinical examination. So why is all of this important? Well, if we see this, it's strongly associated with Demodex blepharitis. Demodex blepharitis is simply an overpopulation of the microbe Demodex within the lash follicle. And by now prescribing lotilaner 0.25% twice a day for 6 weeks, we can actually get rid of that. And the first thing that patients will oftentimes ask me, because I usually set up the first follow-up visit to be 2 months after that, 2 weeks to actually get access to the medication. And then so they can be on it for a full 6 weeks before I actually see what the result is. And when you do that, most individuals are completely clear when they come back. And Tarsus actually did a study where they looked at these patients a year later. 80% of them were still free of blepharitis at that point. So again, that's a fact that I share with patients, and I also share with them. That means 20% of patients had this come back. We'll determine where you actually are on this scale. So one of the other things that we oftentimes overlook, again, are those tools that we have in our practice. Fluorescein staining, I will argue, is one of the most important diagnostic tools that we have. Take a look at the intricacies that you can see of this tear film and how quickly it's breaking up. We expect this to last for 10 seconds, and this is breaking up at 1 to 2 seconds. Again, putting this as a process, every single exam, every single visit, placing fluorescein on the lower palpebral conjunctiva, simply wetting it with either a drop of water or a drop of saline, and then placing on that lower palpebral conjunctiva will give you insights into the tear film that we simply can't get with just a standard white light assessment. And I'll prove it to you. this is an individual on the left-hand side that we're looking at with just a standard white light assessment. In the middle, we're looking at that patient with a cobalt blue light in place. We've placed fluorescein on the eye, but we have cobalt blue light in place. And on the right-hand side, you can actually see the patient after fluorescein's been instilled, cobalt blue light in a rat number 12 filter. And you can see what that tear film's doing. This will start triggering questions in your mind. And when you ask this patient, even in what's considered an asymptomatic patient, and ask them about visual fluctuation, that may be their chief complaint initially. Yeah, I can't hold things in focus. They may actually be in your chair because they think their prescription's changed, when in actuality, it's actually an ocular surface issue that they're running into. This is another example of a patient. And what you can see here, and for those of you that have your lights on in your room, hit your lights for this one so that you can actually see the corneal staining that's present here centrally that you simply can't see when you don't have fluorescein on the eye. And sometimes it's even easily missed when you have fluorescein on the eye, but are looking at it with a cobalt blue light. But here with the rat number 12 filter in place, you can actually see it. So we actually, as a process, we have rat number 12 filters on every single slit lamp in the office. And we actually have anterior segment imaging at every single slit lamp as well too. So we can immediately, with the press of a foot pedal, we can actually start imaging things at the slit lamp for these patients. So what other insights can fluorescein or even lissamine green for that matter give us with these patients? Well, one of the things that we need to be cognizant of is the lid structure and whether or not there's any lid laxity. Because lid laxity can lead to incomplete lid seal, but it can also be a sign of something called floppy eyelid syndrome, which we know is a low level of elastin in the tissues of the lids. And the reason why this is important to know is because a lot of times we'll treat these patients as dry eye individuals, when in fact they don't have dry eye. They just have lids that are loose, and oftentimes the eyes open in the evening. So simply closing those eyes at night is important. But when we avert that upper eyelid, we can assess a tiny little area on the lid called the lid wiper area. Now, you ask yourself, is a tear film breakup time the cause, or is it the result of dry eye? Is corneal staining the cause or the result of dry eye? And I can make a strong case that both of those are the result of dry eye. Again, you have an ocular surface that's not sustaining itself with what it's supposed to in terms of coverage. And those are the signs that you're seeing. What it's incumbent upon us to do then is, why is it not covering itself? Why is it not adequate for that ocular surface? And that's where a close view of the lid margin, assessing for the presence or absence of collarettes, will start giving us some indication on what we feel might be causing this. Lid wiper epitheliopathy is the same thing. Is this a cause or is this a result? And this is considered a result because there is excessive friction on that upper eyelid that's blinking over the surface of the eye because of the absence of adequate tear film that's supposed to be there, causing this staining. What's most important is that when you look at symptomatic dry eye patients and contact lens wearers, 80% of them have lid wiper epitheliopathy. So it's a very, very common sign that we see in these patients. All right. What type of slit lamp and camera do you like best? We utilize the telescreen system in our office. The slit lamp, we use standard Marco slit lamps, and the telescreen system mounts right onto those. Another question that came through. This is off topic with your current lecture, but I am confused when one should use PRP drops, autologous drops therapeutically. Is it recommended at moderate to severe dry eye patients? Is it when a patient has epi defects? Is it when their eyes deeply hurt? Or with patients with autoimmune conditions? I'm going to leave that question towards the end of the discussion because that is a perfect, perfect example of what I'm talking about here. And we're going to come back to that exact same question right at the end of the discussion before we close out. So this is how you grade lid wiper epitheliopathy. This is how it looks like when lissamine green is instilled in the eye. You can actually see the line of marks, which we expect to be in every single patient. We expect it to be a relatively thin line. We expect it to be very consistent. And if there's any irregularities there, or if it's migrating anteriorly on the upper or lower lid, that's a sign of chronic inflammation on the surface of the eye. And we measure the horizontal length and the sagittal width of this to determine whether or not there's in fact changes that are occurring to this when we instigate treatment in these individuals. Another question came through. Do you recommend blink exercises? I used to recommend blink exercises. The challenge with blink exercises is we had a massive problem with compliance with the blink exercises. Do I think there's validity to blink exercises? Yes. Do I think it's difficult to get patients to do blink exercises? Yes. So there are other places we're now putting our efforts when it comes to educational efforts with these individuals or patients. Now, I will share with you that another important facet to view at the surface of the eye is the meibomian glands and the lid margin. I would challenge you to look at it at a high magnification as well too as you're scanning and when you're attempting expression with these individuals. You'll actually see capping of the meibomian glands, which is common with meibomian gland dysfunction, specifically of the obvious subtype. This is the one that will erode contact lens practices. This is the non-obvious meibomian gland dysfunction. So as you can see here, I'm attempting expression with my thumb, but I'm not really getting any adequate oils that are coming out of those meibomian gland orifice. And there are more controlled ways to actually perform this test through things like meibomian gland evaluators, which are seen on the right-hand side here. And this is me on another patient performing the meibomian gland evaluator on an individual who actually appears to have a relatively quiet and normal lid margin, but in actuality, this patient has stagnation within the glands that's actually preventing any oils from proceeding out of those glands. So again, this appears to be one of the major reasons for this patient. So when you ask yourself, looking at the lid margin, is this a cause or is this a result of dry eye? This would be a true example of a cause of dry eye. Again, corneal staining, reduced tear film breakup time, lid wiper epitheliopathy. Those are things that we're seeing as downstream sequelae of the dryness on the surface of the eye. When we're looking at meibomian gland dysfunction, we're usually thinking that this is a cause of the dry eye. So the question that just came in is, how do you treat lid wiper epitheliopathy? That's such a good question. You don't treat lid wiper epitheliopathy. Again, I want to be crystal clear on this. Lid wiper epitheliopathy is a result of dry eye. It's not the cause. So we don't treat lid wiper epitheliopathy. Lid wiper epitheliopathy is a sign. We need to take a step back and say, all right, here's all the signs that we see. We see lid wiper epitheliopathy, we see staining, we see reduced tear film breakup time. But what do we think is causing the dry eye? Then we start treating that. And as we start treating that, we want to see improvement in those things that are resulting from the dryness. Another question just came through. How much is expression device and where do I get it? So the expression devices are relatively inexpensive. I think they're less than $50. And Johnson & Johnson distributes those now. So, when we look at meibomian gland structure, part of the reason we're looking for meibomian gland structure is it gives us somewhat of an indication from what we know now about meibomian gland structure, how long this individual may have had this condition. In addition to that, it gives us an idea of what the treatment outcomes may be if we do in fact treat this individual with an advanced warming and evacuation procedure. So in this patient, I'm not using any advanced diagnostics. All I'm doing is pulling that lower lid down, and you can actually see where the meibomian glands are and where the meibomian glands aren't. This is me taking this image with my iPhone. So again, you get an immediate impression of this by simply looking at the patient without any type of devices other than our own eyes. When you look at them at the slit lamp, you can actually see where the meibomian glands are and where they aren't as well too. Again, this is where they are, and this is where they're missing. When you actually do eyelid transillumination, which is where you leverage that transilluminator and shine it through that lower lid, you can very easily see where the meibomian glands are, where those shadows are, and where the meibomian glands aren't. If you're doing this technique, make sure the lights are off in the room, make sure the slit lamp light's off, and make sure the only light that you're shining through that lid is from the transilluminator. And this is another picture of meibomian gland dysfunction showing where the glands are and where the glands aren't. We're fortunate that we now have published scales, and this was pulled right offline. This is from the Heiko Polt scale, and the only reason why it's called the Heiko Polt scale is because Heiko Polt is the optometrist from Germany that actually created this scale. And again, you either have 0 degrees of loss all the way to massive degrees of loss towards the bottom of the image here. Another question came through. How quickly do you see resolution of lid wiper epitheliopathy after start of dry eye therapy? Good question. It depends. That would kind of be like asking, how quickly do you see resolution of corneal staining when you start treating dry eye? And it depends on what the ultimate cause is and the patient themselves. We sometimes, with some treatments, we see results within 2 weeks. Sometimes it'll take 6 months to a year to actually start seeing any level of change in the corneal staining. So it really depends where that person actually is. This is an example, again, of another infrared image of a patient with full meibomian glands. And the reason why it's important to understand gland structure is because with some of our more advanced warming and evacuation technologies, we actually need to know where the meibomian glands are and where they aren't. The tear care, for example, actually leverages forceps where you actually evacuate the glands after the warming device has warmed the lids. And if you go too deep, you'll be pressing on a region or an area where meibomian glands do not exist. So you need to make sure you know where, in fact, those meibomian glands are and where they aren't. In addition to that, you need to know what the expectations are with treatment. So for this individual, even though I would say they're about 50% reduced, I would still expect pretty good results on either a tear care, iLux, or LipiFlow treatment for this patient. If they had more severe loss where they're missing certain meibomian glands and the glands were even shorter, we're now dealing with an organ that's much smaller in size. So the way that we communicate that with patients would actually be totally, totally, totally different. So we start getting into some interesting areas here. And this next piece for females, you already know this, but for the males that are online, you may not be as astute to this. I started asking these questions about 3 years ago, and I wish somebody would have grabbed me by the ear and said, Neil, you need to start asking these questions much earlier than that. Because what we saw was this recalcitrant dry eye patient in a subset of individuals that really wouldn't get better with topical therapies, or they would wax and wane. And what we realized was this is probably something that has a more diffuse etiology, specifically rosacea. We know that individuals with facial rosacea are much more likely to have meibomian gland dysfunction than those individuals that don't have ocular or that don't have facial rosacea. And again, you can see the classic telangiectatic vessels, some that are more prominent than others, but this hyperemic response that you see at the surface of the epidermis is really from blood vessels that are encroaching into that dermal region where they're not supposed to be seen as densely. And that's what we're noticing. And oftentimes this occurs because there's inflammation that's present around those glands. That inflammation can be the result of a number of things. It can be a simply blood vessel abnormality because of the lack of appropriate sebum that's being produced by the oils in the skin. It can be a Demodex overpopulation diffusely over the face. There are a number of reasons that this can actually occur, but we need to be aware of it. Now, why I share that most of my female colleagues will know about this, but a lot of my male colleagues may not be aware of this, is that when we see females in the exam chair and we're examining the eyes, we assume that when we look at their face, that's just their natural appearance. I would charge you to ask your female patients one question. Are you wearing any makeup today or any type of cover up or anything on your face? And specify your face as opposed to your eyes, because if you just ask, are you wearing any makeup today? They'll assume that you're simply asking about it on their eyes. So ask them if they're wearing anything on their face or any creams that have any type of pigment in them. You'll be shocked at how many people say, well, yeah. When you ask them what the appearance of their skin looks like without their makeup on, are there red areas? Are there blotchy areas? Oftentimes they'll at that point then admit to you that there is. So is this a cause or is this a result of dry eye? Well, the more literature that comes out on these individuals, the more we're realizing that this may be part of the cause, which is why we have options for these patients. We think of potentially orally giving them doxycycline, which works well. It's a very common treatment for rosacea. In addition to that, now light therapies are really being embraced for this because with light therapies, you can actually target different layers of the skin. And there is low light level therapy, which is usually placed away from the face about 6 to 8 inches at different intensity levels that's available, or intense pulse light therapy that's actually applied directly to the face. So there's a few other questions that came through. Does uh, lid wiper epitheliopathy follow SPK resolution? Sometimes yes, and sometimes no. It is totally dependent on the patient. What you'll normally see is if you see one improve, you will see the other improve, but it totally depends on the individual. Sometimes you'll see staining on the cornea improve much sooner than lid wiper epitheliopathy. Sometimes it's the exact opposite. Another question that came through. Any luck with MIBO for lid wiper epitheliopathy? I've had some luck. Great. Oh, Dr. Davidson, what a clinician's clinic. Uh, Josh, that's awesome seeing your name up there. So yeah, we have. MIBO is actually an interesting little nugget that we have because there are some individuals that we either can't get them producing enough mibome or they need some level of supplementation. So MIBO is perfluorohexyloxane 100%, which is really unique for any medication. But what this does is it's the lipid layer that it's receptor. And because of that, you actually now add an anti-evaporative layer to the ocular surface. And with that all said, you actually get pretty good resolution of a lot of these signs, corneal staining and also lid wiper epitheliopathy. Lid margin telangiectasia are MGD, or is it ocular rosacea or both? Anonymous attendee, you asked that question. That is one of the most insightful questions you've asked because those haven't been clearly defined. We typically reserve the term ocular rosacea for those individuals that have telangiectatic vessels, meibomian gland dysfunction in the presence of facial rosacea. I will tell you that oftentimes these people are miscategorized because, again, sometimes people have rosacea. We're treating meibomian gland dysfunction, but we never call it ocular rosacea. So we need to take a step back and start cleaning up the way that we're defining a lot of these things. What dosage do you start patients on with doxycycline? Great question. If we're starting doxy, there's a pretty large scale study. It was published about 15 years ago now, but it actually looked at individuals either being randomized to 100 milligrams of doxycycline twice a day or 20 milligrams of doxycycline twice a day. And they found really zero difference in clinical efficacy, but they found a lot of differences between side effect profile with the higher dosage actually having the higher side effect. So what we typically do is we start 20 milligrams twice a day, separated about 12 hours apart. And we have them do that for about 3 months and we'll see them back. And if we can taper them back at that point, we'll try and taper them back to just once a day. So we have dozens of patients who are just using it once a day. If it doesn't seem to be adequately controlling the symptoms, we'll just up it to 50 milligrams at that point. Which IPL protocol do you follow for rosacea, Toyos, Paramin? Right now, we're actually following the Toyos protocol. What treatment did you mention for Demodex? The treatment is something called lotilaner at 0.25%. That's the generic name for it. It's actually commercially available as Xdemvy, and it's spelled Xdemvy. Is a Z-Pak better than Doxy? Very, very interesting question. There's data to show that a Z-Pak can be just as effective as Doxy. The one benefit to a Z-Pak is that you only need to take it for a specified period of time. The caveat that I've seen clinically, and this is just anecdotally, is that we'll oftentimes have to repeat that Z-Pak dosage. So the effect will last a certain period of time, and then we'll have to restart the Z-Pak. I have the 11-page TFOS dues to report executive summary. Where can I obtain the entire report? Oh, okay, great question. If you Google search dues dry eye workshop 2 report, you'll actually come to the TFOS page where you'll be able to download the whole thing. Do you express glands after IPL? That is such a Good question, anonymous attendee. And it depends. And the reason why I say it depends is I never put an individual through more treatment than they require. What do I mean by that? Well, after any type of light therapy, we actually see the individual back in the office and we assess the meibomian gland functionality. I am convinced that there's two types of meibomian gland dysfunction associated with um, rosacea. Type 1 is you treat the rosacea, meibomian glands get better. Done. You don't necessarily need to warm the glands and evacuate. There's a second type of patient where even after you sequester a lot of the inflammation in the skin around the lids, you actually still, or the telangiectatic vessels around the lids and the skin in the cheeks, you still have some stagnation of those glands. And in those instances, I do express, and I'll usually utilize some type of advanced warming and evacuation technology. I have difficulty knowing when I should order tear care versus IPL or what order to perform these procedures. You are not alone, sister. That is a challenge that I think we're starting to get answers to. Let me explain to you the logic. I think the real answer is in the tone of the face and whether or not there's visible telangiectatic vessels in other places in the face. If there are, I think intense pulse light or low light level therapy is first line, see what the response is, and then we do tear care. In the presence of meibomian gland dysfunction, in the absence of a lot of these other facial features or telangiectatic vessels around the lids, I think it's more appropriate to do tear care first line therapy. About Z-Pak, how long after first round of Z-Pak would you repeat it again? Good question. It just depends on the patient. We've had people who've gone on one Z-Pak, they're done. We have other people who we need to cycle back on it about every 6 months. And when that happens, I actually have alternate conversations with these patients just because at that point, I start to become just a little bit less comfortable with repeating the Z-Pak. And if they have sensitivities to doxycycline, this is where we start talking about light therapy in order to modify some of the sebaceous functionality that we're seeing on the skin and also on the lid margin. I've heard two different types of azithromycin therapy, which is better. Pulse Z-Pak therapy versus pulse 1 gram weekly for 3 weeks. Is there a big difference? It's a great question, and I can't say that I know the answer to that because I'm unfamiliar with the study. The only study that I saw was a traditional Z-Pak compared to oral doxycycline taken every day and following these patients over a 3-month time period. And in that study, both of those were the same. But really with the second one, the 1 gram weekly for 3 weeks, I really am not familiar with that study. So unfortunately, I can't really comment on that. I apologize for that. When it comes to medications, when do you start a steroid as a first-line therapy versus something like Restasis or Xiidra? Great interlude into the next section here. Because as we start thinking about dry eye as a process, we really, and every single person, every single one of us has a little bit of a different process. Intraocular pressure, when we think about glaucoma as part of every exam, it's part of a screening. We ask about family history, and it doesn't determine whether the patient has glaucoma, but it increases our suspicion. Think of the first steps that we can be taking in our office with the tools that we have. And look at every process we have in our office and see how that can help identify these individuals. So let's talk about this process because, again, I'm simply taking this complex condition that I have kind of these like places for each of these tools now because I've been through the process of growing with all these technologies and seeing where the voids and the gaps are and knowing where to insert them. But what's my process when I'm seeing a patient? Well, if it's a new patient and for a regular exam, undiagnosed with dry eye, they get the standard pretest. And if there is any type of complaints of fluctuating vision or ocular discomfort, we then perform a speed and flamm that's added onto the pretest. Every single patient that I see as an exam, this is what I do, regardless of whether or not they're in for an exam or a dry eye follow-up. I put fluorescein on the lower palpebral conjunctiva. That gives me the ability to see a lot of stuff immediately. I view the with a cobalt blue light and a rat number 12 filter, I can see corneal conjunctival staining, I can see tear film breakup time, and I can see the presence of lid wiper epitheliopathy. And I can also see what the line of marks physically looks like as well too, and whether there's anterior migration or whether there's any type of irregularities to it. It's just become a process. It's a habit at this point. Initially, I stumbled a little bit, but as soon as you get good at it, you can do it no problem. And it becomes a process with every single person. That's my initial screening for everybody, period. And then what we do is we take a step back and I look with a low and a high magnification along the lid margin as the patient's looking down. And then I assess the meibomian glands by applying a light pressure to the lid margin. And then we perform lid aversion. The reason why I do all that other stuff secondarily is because I want to see the tear film almost immediately without a lot of manipulation by myself. And then I'll sometimes do transillumination. If everything looks good and everything's functioning well, there's really no reason for me to do transillumination. If there's any problems, then I start the further investigation. That's where I do transillumination. And then my follow-up is identical. The only difference is that patient doesn't get pretest the second time. It's a history with the technician, a speed and flam dry with the technician. Then I do the exam from there. I will share with you a nugget that I got from a dentist several years ago. And for those of you that are starting to incorporate these processes in your practice, consider going over your schedule in the morning with your lead technician so that they know what to expect with all the patients that you're actually seeing that day. And they also are prepared and ready so that if you're doing any procedures on those individuals or those patients, they have all the tools ready for you. So when you're walking into the exam room, you don't have to reorder stuff. This is even good for non-dry eye patients. If you have a MAC-Degen patient, why not take the OCT as part of the pretest as opposed to wait until they're dilated? Most of these advanced OCTs can now get through undilated pupils of about 2 to 2.5 millimeters. Information is accumulated. So what we're now starting to do is through all of that process that we just created or just started or just talked about, we're accumulating information and diagnostic information. And again, I didn't really do anything crazy or fancy. Other than the inflammatory, I'm not using any advanced technologies. Yeah, we're bringing in lactoferrin testing in the next 3 weeks. So we're excited about that. I think that's going to give me additional insights. But all of the other stuff is being done at the slit lamp with just simply vital dyes. We need to remember that when we look at things, especially things like corneal staining, these are downstream sequelae of what we're actually seeing. It's not the cause of the dry eye, it's the result of the dry eye. So as we're creating our treatment protocols and accumulating all this information and realizing that most dry eye is a combination of evaporative and aqueous deficiency, the challenge for us is, from what we've just seen, what do we feel clinically is causing most of the insult? So again, we start with the lids. Are the lids functioning well? And we think about meibomian glands, and we need to dig deeper on this one. If we don't see expression, why don't we see expression? If we don't see expression and we see inflammation, is there other inflammation on the face? Asking individuals that may have things that are covering up the natural appearance of their skin. Think about inflammation control and tear production. Inflammation control through either corticosteroids, cyclosporin, and there's a variety of forms now, lifitegrast. There's, again, a number of different ways that we can control inflammation. We can also think about tear retention, improving meibomian gland functionality, adding perfluorohexyloctane to the surface of the eye to act as an anti-evaporative layer. These are all strategies. So the question came up, when it comes to medications, when do you start a steroid as a first-line therapy versus something like Restasis or Xiidra? What I use as my clinical guide on that is how symptomatic the patient or the individual is. But there's one important thing that you need to keep in mind. And this is one of these things that we subtly introduced in our clinical protocol about a year ago. And now for any new dry eye diagnoses or anybody that's non-responsive symptomatically to our therapies, we're putting this test on every single one of those individuals, and it's the Prepare-Cane test. For those of you that are unfamiliar with this will change the way you communicate with your patients. And the reason is If you place a drop of proparacaine on the eye, you expect a dry eye patient to feel and get better. So this is the way the test works. Patient is in chair, patient is symptomatic. You ask the patient to rank the symptoms on a scale from 0 to 10. 10 is the worst they can picture their eyes feeling. 0 is the best they can picture their eyes feeling, okay? They'll give you a number for the right eye and the left eye. You put a drop of proparacaine in the eyes, wait 90 seconds. Ask them to grade the symptomology again, 90 seconds after. If they see a massive drop, you know that if you can control what's happening on the surface of the eye, that's what that patient's feeling through those trigeminal nerve endings. If the proparacaine doesn't make these patients feel better, you know that there's a secondary cause to the perception of the uncomfortability that they're feeling, which is oftentimes put in a bucket of neuropathic dry eye. So in this instance, with this question, when it comes to medications, when you start a steroid versus as a first-line therapy versus something like Restasis or Xiidra, if the individual is highly symptomatic and there's visible signs of corneal staining, we'll concurrently start them on both if they pass the proparacaine test. When I put proparacaine on the eye, it drops the perception of their uncomfortability quickly. If we put proparacaine on the eye and it doesn't drop it, there's a lot of movement in the literature on this. Some treat with autologous serum over a year to really help manage the communication between the trigeminal nerve and the central nervous system controlling the pain. What we've actually had good success with in these individuals is we've actually started these patients on varenicline nasal spray. And we're not sure the direct mechanism of action, but we're realizing that there is some improvement in some of these individuals. When you activate the trigeminal nerve within the nose, it's communicating back to the central nervous system, telling the central nervous system to feel better. And what we're finding is some of these patients can actually tell when the effect of the varenicline is worn off. So they come in asking, Doc, can I take it after 9 hours or 10 hours? Because I can start feeling my eyes again after like about 9 or 10 hours after that first spray. And we say, yep, no problem. Have you noticed any differences in the efficacy of the current 4 topical cyclosporin drops? Yes and no. And the reason why I say that is some people, we've actually had to have them on the various drops because of insurance accessibility. Other times we have not because we don't have that comparator. What I can tell you is Josh Johnson actually did a study where he compared individuals taking 0.05% cyclosporin and he switched patients that were unsuccessful at 0.05 to 0.09% cyclosporin. And he found an overall improvement in signs and symptoms in those individuals over a 90-day time period. Are there any instances where you would prefer Zest treatment with Zocular to lotilaner drops in Demodex treatment? That's such a good question. Unfortunately, I don't personally use the Zocular treatment. I've heard great things about it, but I will just share with you that I've had such good success with the lotilaner that I'm really not modifying that blepharitis treatment at this point, and it's easy for me to do. It's a drop that somebody uses for 6 weeks at home. Is your finger as good as a meibomian gland evaluator? Good question, anonymous attendee. And I would say, yes, kind of. I'll put it to you on a scale. Pressing with the finger is better than doing nothing. Using a meibomian gland evaluator is better than doing it with your finger because it's a more controlled environment. Saying that a meibomian gland evaluator can't just be picked up and utilized along the lid margin. You actually do have to practice how to use it. A few times you may kind of accidentally push it over the lid margin. So after you do about 30 to 40 of them, you get very, very fast and very, very proficient at it. But at first, when you try it, it does feel a little bit awkward. And you tend to not want to get as close to the lid margin as you're supposed to be. How would you deal with dry eye for those who are unable to afford dry eye procedures and newer drop therapies? Oh, this is like a daily thing in my practice, and I'm so glad you shared this. I can't make judgment calls for patients. So what that means is I can never limit what I share with individuals about treatment options, in particular when we're offering them in the practice. What I can tell you is I always give them the options. And I say, this is what I think would be best for you, but this does carry a cost and this is not covered under medical insurance. They say, Doc, I can't really afford this. I say, no problem. I say, Let's do the second best option. And I give them another option. If they're not as well as we would hope them to be, I always go back to say, remember what I said I felt would be your best option. Now, what is interesting, as we've started to get more into the light therapies, specifically low light level therapies and intense pulse light therapies, in addition to improving their dry eye symptoms, for those of you that are performing these in your practice, you know they have two side effects. The first is they reduce hyperemia on the skin surfaces that the light's applied to. And the second is they actually tighten the skin that is exposed to the light levels. So what that means is sometimes individuals actually, just as much as being alleviated from the symptoms of dry eye, they also interestingly enjoy the side effect profile just as much as the therapy. And it's amazing how people can find the cash when it has that level of side effect. Um, for Prepare test, how much drop would you consider a pass and how much would be a fail? Oh, so yeah, good question. Let's say, for example, you start symptomatically at an 8, and let's say you go down to a 6. If you do that, that means there's a heavy neuropathic component. And this is what you'll find with a subset of these individuals. They'll get a little bit better, but not a lot better. What if you go to from an 8 and go to a 4? There's a heavy neuropathic and ocular surface component to this. If you go to an 8 to a 2 or a 1, that tells you that if you rehabilitate the ocular surface, you're probably going to make these patients better. So if you get a 1 or 2 point drop, or at some points you'll actually see the patient elevate, they'll tell you that their eyes are more uncomfortable after the drop. That's a heavy neuropathic component. Even if it's a 50% drop, you still have to describe the neuropathic component as well to those individuals. Okay, if you were going to sell a dry eye drop in your practice, which one would you recommend having for your patient? Oh, that is a very interesting question. And that is the most difficult question I've received because we use a variety of dry eye tears. And one of the things that I'll share with you is that we immediately look for drops that are preservative free that come from companies that we trust. All of you may be aware of this, but if you're not, 40 eye drops, artificial tears, were recalled because they were causing infections. A few of them actually caused death to patients. So they need to be from companies that you trust. We enjoy the drops that actually are in large bottles that don't have preservatives in them, that contain engineered one-way valves. And we like the drops that contain trehalose and sodium hyaluronate. But to name one is very, very difficult. Do you recommend omega-3s? We do. As a general rule, omega-3s are good if, when you look at the side of the fish oil bottle, let's say you have a 1,000 milligram fish oil capsule, it has to at least be 70% omega-3s to total fish oil in order to be a good quality fish oil. Saying that, there was just recently a nutraceutical that was approved to treat dry eye. It's actually called NutriTears. You find it, or patients will find it, in the artificial tear section, and it contains high levels of lutein and zeaxanthin, which is interesting. Lutein and zeaxanthin we've typically thought of as back of the eye helpers, and in this instance, they actually are been found to improve signs and symptoms of dry eye.